Okay, my name is Evelyn Fox, and this is my son. He'll be DJ for the purposes of recording this video, and um, we'll get consent before we begin. The video will be only viewed by my professor for grading purposes only. Is it okay if we proceed with making the video?
That's fine.
Okay, we'll start. Just gonna show you my index card is blank. I just use it because I can't see the numbers on the ruler unless it has a white back. Okay, I'm gonna start by saying that the blood pressure would be measured in a supine position and then the upright position in bilateral upper extremities prior to beginning the exam, assessing for orthohypotension. I'll begin by just looking at the neck in attempts to try to locate. I'm going to ask you to turn your head a little bit to the left. And I'm looking for the jugular vein. His is very difficult to see at a 30-degree angle. So I'm going to place my ruler at the vertical angle here at the sternal notch. I mean at the sternal angle in a vertical position at the sternal notch. I'm going to create a horizontal line at the highest point in which the jugular vein can be observed, and that is here. It's going to be horizontal, and then I will look at the number. He is at 2. So the jugular venous pressure is 2, and that's a measurement of the internal jugular vein from when measured between 30 and 45-degree angle at the highest point of observance. When you create a horizontal line from that point to the sternal notch at a vertical angle with the ruler. Next, we'll move on to, I'll sit down here. I'm gonna look at you and turn your head to the front. I'm going to assess the carotid arteries. I am not going to do it bilaterally because that would be an issue that may cause him to have a drop in blood pressure and possibly a syncope episode. His carotid pulses are palpable, and also I will avoid palpating them up high. Right carotid artery has a normal upstroke and brisk. Left carotid artery, normal upstroke, brisk. Next, I'll auscultate. I'll auscultate first with the diaphragm. Assessing for bruit, negative for bruit. No bruit on the left. Listen to the back, the bell. regular. And very audible with no bruit. Next, I'm going to move to the chest area. I'm going to look at the chest for symmetry to see if the chest is symmetric, and to observe any abnormalities that could possibly be present on the chest, surgical scarring that I might need to ask about, or pulsations primarily is what I'm looking for at the precordial locations, as well as the apical pulse. The apical pulse is located here at the apex of the heart, which is the fifth intercostal space and midclavicular. His apical pulse is not visual. Next, I'll palpate. I'm going to palpate the second intercostal space. This is a assessment looking for heaves or lifts. The second intercostal space is the aortic valve. No heaves, lifts. The pulmonic valve at the second intercostal space on the left. The third intercostal space on the left at Erb's point. The fourth intercostal space, the tricuspid valve, negative for heaves or lifts. The fifth intercostal space at the mitral valve, the apex, the maximum point of intensity, and where we would observe apical pulsations. The maximum point of intensity is palpable here. I would rate his at a 1. It's not very strong. It's kind of diminished. Well, no, it's a 2. I'll give it a 2. I had my, when I apply low pressure, 2. The next thing I'll do is auscultate at the same points. Second intercostal space on the right. I'm going to listen with the diaphragm first, and at the intercostal spaces alongside the sternal border. Second intercostal space on the right, aortic valve. S1, S2. Audible. No murmurs. The pulmonic valve, left intercostal space 2. Left intercostal space. The third intercostal space on the left is what we call Erb's point. It is also the place where you assess for the splitting of S2. I'm going to ask you, on inspiration, the splitting of S2 is normal. The splitting of S2 is caused by the closing of the aortic valve and the pulmonic valve not in sync. They don't close simultaneously on inspiration. And the aortic valve, the closing of it, A2, and the pulmonic valve, the closing of it is P2. A2 is appreciated throughout all listening points. However, P2 is only observed at the left second intercostal space. Therefore, we choose between the third and fourth intercostal space. That's a perfect area, or the area that you would listen to for the splitting of S2. Okay, I'm going to ask you to inhale slowly. Okay, you can exhale. Inhale slowly. Okay. I'm not able to appreciate the splitting of S2 on inspiration for him. I'm going to go down to the fourth intercostal space along the sternal border, which is the tricuspid valve, and on down mid-clavicular, fifth intercostal space, and listen to the mitral valve. S1, S2 present at all valves. No other cardiac sounds. Abnormal. We're going to listen to aortic with the bell. Pulmonic. Third intercostal space, Erb's point. Fourth intercostal space, tricuspid valve. Fifth intercostal space, mid-clavicular. Point of maximum intensity. Mitral valve, apex of the heart, apical pulsation, all present in that area. Very good. Okay, I'm going to visualize the abdominal aorta, and there's no pulsation or nothing unusual about that. That would indicate that he would have a abdominal aneurysm in the aorta. Next, I'm going to palpate to feel. Sorry if I'm pushing too hard. +1, but no thrill. I'm gonna listen with the bell and the diaphragm. Diaphragm first. Normal, no brewing. No brewing. Next, I'll move on to the extremities, bilateral upper, bilateral lower. I'm going to look at the color the hair distribution of the skin all over both extremities. I'm gonna assess the nails here for capillary refill, clubbing, cyanosis. I also assess the arms for shunts, fistulas, or anything else that may be present. I'm gonna look at the legs. They're normal in color. A lot of times if somebody has peripheral vascular disease, you'll see shininess and patches of hair missing in that area because the vascular access to the lower extremities, or even the upper ones, most commonly the lower ones, is diminished because of blood flow. I'm assessing the nails once again on the toes for cyanosis, clubbing, splinter, hemorrhaging, and the upper for tar staining. All of his are less than 3 seconds, which is good. Next, I'm going to palpate the arteries of all extremities. I'm going to begin with the radial artery on the right hand. That's lateral to the thumb. With 2 fingers, I'm going to rate it on a scale of 0 to 3, 0 being none, 1 diminished, 2 normal, and 3 bounding 2. I'm going to assess the brachial, mid bicep, and in the antecubital region for brachial. +2. No rapid, thready, or bounding pulse, rapid, thready, or bounding. I'm gonna do the same on the left. On the lateral side of the thumb, I'm gonna assess the 2. I won't be in the camera's way. And 2 for the brachial on the left. Next, I'm going to assess the artery in back of the knee, the popliteal. +2 in regular, no pauses or rapid threadiness that would be indicative of some other issues. Dorsalis pedis on top of the feet. I'll do them individually. +2 on the right, +2 on the left. Posterior tibial, right behind the ankle and runs down. +2. Some people, this is very difficult to find. You have great pulses. +2, easy to find. I'll go back to the inguinal area where I'll assess the femoral artery. Don't worry, I'm not going to pull your pants down. I'm going to palpate the femoral arteries. +2 on the right, 2 on the left. Audible, no bruit. No bruit. No bruit. No bruit. Okay, this concludes our assessment for a cardiovascular system. Thank you.